Good afternoon, folks. This afternoon's B, we are talking about whole person palliative care models. Okay, so that is today's B for you. I'm going to discuss that and see where it goes. Remember, I always say that if anybody has any comments, questions, things they want to add to the topic, leave it in the chat below for me, please, and I'll see what I can do about getting you answers, doing shows, extending topics, those kind of things. So here we go. Whole person palliative care models recognize something profoundly simple and profoundly radical. People do not die in pieces. They do not suffer in neat and neatly separated categories. Their bodies, histories, fears, relationships, hopes, and identities all converge in the experience of serious illness. The most effective models honor this reality by weaving together medical care, emotional support, spiritual meaning making, social connection, and personalized integrative therapies into a single coherent approach. These models are not soft or adjunctive. These they are evidence-based, outcomes-driven, and increasingly central to modern healthcare. Systems that understand suffering as multidimensional and healing as relational. What defines a whole person palliative care model across global research and practice? Whole person models consistently include early integration. Palliative care begins at diagnosis of a serious illness, not when treatment stops. Early integration improves hospitalizations and ensures care aligns with what matters most to the patient. Multidimensional care, physical, emotional, social, psychological, and spiritual needs are addressed simultaneously, acknowledging that distress in one domain amplifies distress in others. Personalized integrative interventions, massage, acupuncture, mindfulness, music, therapy, aroma, and other modalities are used alongside medications to reduce suffering and enhance comfort. Spiritual assessment and meaning making. Tools like NIH, HEALS, and FICA help clinicians explore meaning, identity, legacy, and external distress, domains that often matter more to patients than physical symptoms. Interdisciplinary coordination, physicians, nurses, social workers, chaplains, therapists, and integrative practitioners collaborate to create a unified plan that adapts as needs evolve. Whole person models are not defined by any single therapy. They are defined by the coherence of the whole evidence-based elements of effective whole person models. A major rapid review of palliative care models found several components and consistently improve outcomes across settings and populations. Case management, the strongest evidenced or evidence supported component. Case managers ensure continuity, anticipate needs, coordinate services, and prevent crisis. Communication and coordination. High functioning models rely on seamless communication across home, hospital, long term care, and community settings. Skill enhancement, training primary care clinicians and community providers in foundational palliative skills, expands reach and reduces fragmentation, rapid response capacity, the ability to adjust care quickly, same day visits, urgent symptom management, crisis prevention is essential for maintaining stability and dignity. These elements matter more than any branded model because they are the predictive drivers of better quality of life, fewer hospitalizations, and higher family satisfaction. Holistic domains within whole person palliative care. Whole person models typically organize care around the around five interconnected domains: physical care, pain, dysphagia, nausea, fatigue, sleep, mobility includes medication, integrative therapies, and comfort focused interventions, emotional care, anxiety, depression, anticipatory grief, supported through counseling, mindfulness, narrative work, and therapeutic presence, spiritual care, meaning, identity, forgiveness, legacy, ritual, and connection to beliefs or values, social care, family dynamics, caregiver burden, financial stress, community resources, and relationship strengthening, psychological care, coping strategies, trauma informed care, resilience building, and mental health interventions. These domains are not separate solos, they are threads in the same fabric. Examples of whole person palliative care models in practice: integrative palliative care. Academic centers blend conventional medicine with acupuncture, massage, yoga, and mindfulness to reduce suffering and enhance well being. Community based palliative care. Home based teams provide early support, caregiver coaching, and across continuity across settings. Population based models. Systems integrate specialist palliative care with primary care, oncology, geriatrics, and community services to create seamless pathways. Whole person healthcare frameworks, root causes focus, value alignment, shared decision making, and lifestyle integration, increasingly adopted by health systems seeking to improve outcomes and reduce costs. These models differ in structure but share a common ethos: care that seem care that sees the whole human being. Where you might take this next, given your work in palliative care, long-term care reform, and narrative-driven policy, the next step could be whole person palliative care policy models, embedding these elements into uh, reimbursement, workforce development, and quality matrix, training models for interdisciplinary teams, building competencies in meaning centered, integrative, and relational care, designing whole person care pathways, mapping the journey from diagnosis through bereavement across home, hospital, and long term care. Okay, guys, that is your B for today. I'm going to take a little break. I'll be back on shortly with C. So I will see everybody shortly for C. For now, Gator Wellness, take care, folks.